So I'm going to be talking to you today a little bit about the challenges that we've been facing at the Prince of Wales Hospital in Sydney, and probably similar situations have been faced across the country with the growing number of cases. I get people, we're talking about people here, growing number of older people having to make very serious life decisions in an acute hospital setting when they're in crisis, and how do we cope with that in the healthcare setting. For those of you who were in this room for the previous session, there was a very interesting talk about, presented on 6 cases where the medical and other allied health professionals were faced with such questions and could be argued did a good, bad, not sure job of that. So I just want to talk to you about what we've sort of tried to do at Prince of Wales from the psychology department. So just want to put it out there that everything I'm going to talk about is with these assumptions, that all rational people, all of the assumptions that we've been talking about at this conference over the last 2 days apply to this talk. So we all have the freedom to make decisions, whether they're good or bad, about all aspects of our own life. I would like to speak on the behalf of my profession. Clinical neuropsychologists would not go into an assessment with a preconceived notion about how we're going to, what opinion we're going to give on that person. Capacity is always assumed. I actually prefer not to call it capacity when I talk about the issue in my reports. I tend to talk more about decision-making ability, and I tend not to talk about incapacity, but more whether their ability to make informed decisions has been compromised in some way or another, not that they've lost that ability altogether. So just wanted to make those disclaimers in case I don't do it later on and you all think that I'm working unethically. So just as a background, the Prince of Wales Hospital, for those of you, probably most of you don't know what it is or where it is, it's in Sydney. It's a major teaching hospital. According to our website, we have 571 beds. I think that includes day treatment beds. Geriatric medicine comprises 37 acute beds. 6 are in a locked unit, which brings up its own ethical considerations. People do need to consent to be in the locked ward, or their family needs to consent. There's also a geriatric medical assessment unit and 21 rehab beds. Given the pressures of the hospital, and that's partly what I want to talk about today, that on any given day there could be up to 20 geriatric patients sitting in their beds in outlying wards. So whether there could be an renal ward, busy surgical ward, orthopaedic ward, oncology ward, wherever. So my position has been in place at Prince of Wales since December 2004. Initially I was part-time, position was made full-time given the need, which I'll show you in a minute. So there has been an increase in referrals over this time for a range of different reasons. The main one we're talking about today would be for, I'd like to call it capacity assessments in quotation marks, because often the doctor will say, need you to assess capacity. And that will be all they will say. So we had to have an approach to try and explain that actually need a bit more information than that. So some of the areas that I have been asked to assess people's ability to make decisions about treatment, about discharging against medical advice, about discharge destination, about what services they can have, and problematically sometimes you will have people deciding that now's a good time to make a will or appoint someone as power of attorney when they're quite acutely unwell in hospital. So just this graph it's not very exciting. It is to me, because these are the number of referrals that I have each year for neuropsychological assessment for just me as one clinician. The darker columns are capacity referrals. So we're talking in 2009 and 2010, up to 80 to 85 referrals a year that I would be getting to assess capacity. So no small number. And, you know, I get like 220 odd referrals a year for people to assess for neuropsychologically. I do also cover Sydney Hospital, which is on Macquarie Street, centre of Sydney. Often the cases that I'm asked to see there are homeless, people with alcohol dependence who are maybe making that decision to go back to homelessness. So fairly complex cases. So just quickly about what the neuropsychological approach to assessment of decision-making ability is. We'll do an assessment, comprehensive assessment of cognitive function using formal tests, but there will also be investigation or targeted interview approach with people, exploring their understanding and reasoning abilities in regard to specific issues. So we're more interested in how people make decisions, not the decisions that they're making. And I think that's really key for all assessment of this nature. So assessments of decision-making ability are time-consuming, as they should be, and I guess a regular neuropsychological assessment can take up to a day, including report writing, scoring and so forth. For assessment of decision-making ability, it's generally a lot longer, and with good reason, because these are fairly serious issues. So the main issues I wanted to talk a little bit about, just bring to light, I guess. There's been a lot of talk at the conference about the legal issues and so on and so forth, but looking at what it's like to work in a busy hospital, it's really hard to balance the pressures of length of stay, bed availability, like hospital bed availability. I know one of the speakers in the last session talked a little bit about non-medical admissions, and our doctors will say that it's a social admission, and some education needs to go on about that actually it's not. It's somebody is in hospital because they're not coping with their social condition because of their medical condition, which may be dementia or brain injury or alcohol dependence and so forth. So there are issues around duty of care, there are issues around judgment, judgments over what's the best decision, what's the right decision. Somebody can't live like this, we can't let them go home to that. All of those sorts of things come up every day, and I would like to say that in our team at least, we certainly discuss these issues at length and more than a couple of minutes a week. So, and particularly if there's a complex case, it will be, you know, there might be a team of 15 of us talking about one person for up to, you know, half an hour to an hour. I know that doesn't sound like much, but in a busy ward, it's a fair amount of time. It's been important to drive home to treating teams that disagreeing with them doesn't mean that somebody lacks capacity, and that's a fairly common issue. Oh, they don't want this, they can't make the decision, clearly. That's not right. And again, the unusual or eccentric ideas versus the sort of normal values, or I guess what we're saying is upper white middle class values often is the case. And also a big problem is people's ability to thrive in the hospital environment. I know that was spoken a little bit about in the previous talk about alcohol-related brain injury. So people, when they're no longer intoxicated, will make very different decisions than what they may make when they're intoxicated. Likewise, when somebody's nourished and feeling clean and comfortable and warm, they might make different decisions than what they would make in the community. One of the things I've been trying to drive home to the team is that capacity, as you would all know, is specific to decision, domain and time. You can only assess for capacity at a given time for a given decision. And it's not always permanent, could change. And the issue for me is that usually assessment of whether somebody can make a decision about something is going to happen if it's about accommodation, it's going to happen right at the end of their stay in hospital because they're ready to go and it needs to be done now because we need this bed. But it takes time. And so often you will get these preemptive strike kind of referrals. Oh, we're going to need a capacity referral, capacity assessment, but the person's still in ICU or something like that. You can't do that, and that's been hard to get drive that home. We've talked a lot about that at the conference, don't need to reinforce that. So what we decided to do was to try and give a bit of education to staff at the hospital and developed a bit of a flow chart to sort of guide the need for referrals. So one of my colleagues, Alana Hepner, and I got together and worked out what would we want to do. So she works in a different part of the hospital where they were seeing an equal number of referrals. And I have to say that in my neuropsychological training, we didn't get a whole lot of education on this area. And I would say that in the medical and other allied health professions wouldn't get a whole lot of training in it either. Sort of things that you have to learn as you go along. So part of that is educating our own profession about how to go about this and how to cope with it. So got some feedback and presented it to social workers. The spinal injury unit, we have a spinal ward at our hospital where a number of referrals come from as well because they can't get people out, basically. And I know I'm running out of time, I talk too much. So we did try and base this on some legal standards. I'm certainly not an expert on legal standards, but they're up there and they're in my references. So I'm just going to summarise for the flowchart. We basically summarise that a capable person, number one, knows and understands the issues at hand. If they don't, they need to be properly informed. They appreciate that the information applies to themselves in the situation at hand. And I think that's really important, that it's quite, I know that we'll probably hear about some hypothetical situations as a way of assessing capacity, but I think sometimes it's difficult to do that because we don't know how we're going to make a decision until we're actually in that situation. And having seen people in the spinal cord unit, that it kind of drives it home too, that a lot of people say, oh God, I'd rather be dead than have a spinal cord injury. But the reality is that most people that have a spinal cord injury, highly resilient and are really do want to live. And so you don't know. And I'm not saying that everybody thinks I don't want to have a spinal cord injury, but do you know what I mean? So you don't know what decision you're going to make until you're in a situation. They must know and understand the possible choices. They have to be given the choices, obviously, and they need to appreciate possible risks or consequences. And if they aren't able to identify them, they need to have them explained to them and then see if, now they do know what they are. So it's not rocket science. And I guess also their decisions aren't based on delusions. So this is our very unfancy looking flowchart, which I'll just go through very quickly. So the most important thing, which was the biggest flag for us, was for the medical staff to think about was, is there a need for a decision to be made? And that's what I was talking about before. It can't be preemptive. You need a valid reason to assess capacity. Not just when they don't agree with you. So you need to know, are they able to consent or decide about what? And then the next section is the patient aware that they need to make a decision? And I know this might seem a little bit silly to some of you, but it's quite common that the person doesn't actually realise that there's a decision that they need to make, or that somebody else thinks they need to make a decision. And there's a whole lot of ethical, it's a minefield, basically. And so the prompt is discuss with the patient the need for the decision to be made, including what the choices are and what the risks and benefits are. Then the next section just says, is the patient able to demonstrate that they can understand, use and weigh up the information provided to them in order to make the decision and communicate their wishes? If they are, capacity assessment may not be required. If not, does somebody else hold legal authority? So it's just sort of these prompts that a lot of particularly the more junior doctors don't know about, things like a person responsible, which is New South Wales term, I think, or what the procedure is for supported decision making. And then the next section is, if you're still not sure, please give us a call and we can talk about it, whether an assessment needs to go ahead. And it's also got the flag there about if there's significant disagreement between family members, which is often the case in hospital in a crisis situation, or the patient is adamantly refusing what the decision was made by, say, their next to their wife or their husband or their whoever it is, then maybe it needs to be escalated. So our future plans are to come up, so people in response to this have said, well, but what questions do I ask them? How do I go about this? So our plans in the future are to come up with some suggested ways to engage with the patient in talking about these things and finding out, you know, how to talk to people about these things, and perhaps more sort of flowcharts. We need sort of really basic stuff to give to really busy health professionals. So maybe some flowcharts with specific examples or for specific situations such as guardianship tribunal or consent, other things like that. And just a little joke before. I usually have this little one in between the legal standards. So there's evidence that says that when legal standards are used, clinicians, there's more inter-rater reliability. So people tend to concur in what their decision is. And I think that that's another important thing about the hospital setting, is that it isn't just one clinician working in isolation. I think it's a strength of the hospital setting that there are a number of voices all having input into what are really very important, potentially life-changing decisions for people. And there are some references, if anyone's interested, so I think that they're going to be on the website or something. And that's all. So thank you very much.